So 70-year-old, hypertension. She's got paroxysmal AFib. She's a diabetic, hyperlipidemia. She's a smoker, CAD, multiple PCIs. Here was claudication, progressive rest pain in the left lower extremity, Rutherford category 4. Her ABI on the left is 0.67. She had a recent intervention on the right side. And an ultrasound shows an SFA total occlusion on the left. In January 21, she had a left SFA proc Zilver 6x140 and the mid a Zilver 6x660. And then she has a long supera distally of 55x150. This is a picture of her. Here's an iliac angiogram. Very slow coming up over here, but you can see she's got a patent stent in the left external iliac and absolute pro, and then a patent right in, iliac as well. And her runoff here, you can see a very long segment CTO reconstituting basically the proximal portion of the popliteal artery with really a two-vessel runoff with a posterior tibial occlusion and an AT and a perineal that are going all the way to the foot.
All right, well, fantastic. So we have this case. So Dr. Kapoor and I just took some pictures. You can see this is the intervention that was done before. Not really that relevant. Iliac you saw was done, but this is really what we want to show you. Our partner, Dr. Karthik Guja, who's the associate director of our program, is here as well. You can see here that we chose a 7 French sheath because obviously it's an ISR case, and I think it's a good thing to do. Go to sheath up a little bit to be able to have the options to do different products, which we'll talk about. Yeah, so you can see here the profundo fills very, very rapidly. The stents are down, and it's a full metal jacket that was performed. Next. And you can see that the full metal jacket at the above knee pop around 10 is where it ends, right at that spot, and there seems to be reconstitution. And the runoff is two vessel down to the foot. And you can see here it's got a healthy AT, a healthy perineal. Next, please. Mm-hmm. And then the PT is occluded for a long segment and comes back at the level of the foot. And next, please. And you can see here that you have a beautiful arch that's formed by the AT and the DP, and you can see that the PT does fill very late through the arch, and you can see right there the lateral plantar. You can see in the medial plantar as well.
Right. So I think it's a good point brought up by PK about first determining what size of the sheath you will use. The 7 French sheath gives us a lot of flexibility in the form of visualization while using devices, as well as using multiple modalities. So you'll realize that if you use a 6 French sheath, then it becomes harder to visualize, especially if you have stents like putting it in. But a 7 French gives us an option of visualizing, taking multiple devices, bigger luminal, like let's say if you want to use a directional atherectomy, you could use that. If you want to use aspiration thrombectomy, then bigger catheters like penumbra and all the other catheters can be used as well. In regards to crossing, I'm sure Karthik is going to talk about it as well, but if there's a nub like this, which is more favorable in this case, we start with an 035 system up front. Sometimes you'll see us using an 014, 018 system, depending on how the anatomy is, if it's flush occluded versus there's a stump or not. But as you can see, PK is crossing with an 035 catheter as well as an 035 wire, and we are through the stent. So so that becomes very favorable as well.
So all I'm doing is just gliding the catheter with the wire leading me, and I'm noticing when it's getting caught under the strut to pull the wire back and just torque my catheter and just push it through. Because it's more unlikely that a catheter is going to get under the strut than a wire. Yeah. So don't get worried too much about pushing these catheters. These catheters are quite flexible, and we're just using an aqua tempo.
Very, very thick.
Yeah, you're right, Karthik. Distal cap is very thick, and so now we got good blood flow. So now we're just gonna now what you saw the two vessel runoff, Karthik. Vishal, what are your thoughts now in what you're gonna do before we go ahead? I know our algorithm is very set here in Sinai. We've done it numerous times in live as well as in other areas.
I would say, PK, even if there's a 3 vessel runoff. In this, when you have instant restenosis like this long of an instant restenosis segment, you would probably definitely want to put a filter.
Right.
No matter what, because there's always some thrombotic component. So you definitely don't want to take any kind of a chance.
Yeah, I think, absolutely. Karthik, like talking about, it's always a combination of the way the catheter, like Pika's talking about, the way the catheter behaves, gives us a good idea of the thrombotic burden. Of course, in addition to presentation, the thrombotic burden of the lesion itself. So, like PK and we all published a paper for use of filter, in what cases we use the filter in, and this is one of the indications is long CTOs, calcified segments, one vessel runoff is where it's indicated, or I can give you a
If it's a
roadmap.
short segment thrombotic component and the vessel size is very large, I usually go with Medtronic filters, which are spider filters.
Yep.
You can go with a large filter, which is you can go up to 7.0 if I'm not wrong.
Right.
Filters. But if you have a long segment component like this with a lot of instant restenosis where you think that the filter will have a lot of movement and the vessel size is between 5 and 6, the popliteal size is between 5 and 6, you want a filter which is independent of the wire.
Right.
Like the wire can move, but the filter that way. First of all, I don't know if there's a lot of difference in the amount of thrombotic burden you will feel. I think both filters will catch the filter burden, but I think the radiation burden you'll have by constantly checking the filter place is going to be less.
Filter. So what Vishal and I and Karthik are going to do now for everybody is IVUS. Look, I mean, unlike the coronary space, the definition for IVUS is, or the defined utility IVUS is very well defined in the venous space and is getting more defined in the arterial space. So as you can see, there's a JACC Interventions paper that came out about a couple of months ago, I would say maybe end of last year.
Right.
And the Vishal, sorry about that. And the JACC Interventions paper showed there was a better patency associated with IVUS use with DCB than not. So there's your chroma flow.
Yeah.
So as we come, we know that this is going to hit the occluded segment.
Correct.
You can see there's a little flow in and around with the collaterals, but you can see the amount of plaque burden that we're dealing with. The plaque burden is just so high in the endovascular space, especially in ISR, as compared to, this is not ISR, this is just plaque. This is distal. You see calcified, fibrocalcific plaque with no flow in this area, which we cross. But you can see we're truly within the vessel architecture as we're crossing this, and now we're inside the stent. You could see in the stent, obviously, the stent is crushed inward. Not really, but I think it's just the plaque that's there. And then as you see, we're coming back. It's just a completely occluded stent. With neointimal hyperplasia, I don't see any sort of anything that thrombus or anything free floating that I need to be concerned about. What it tells me.
No, I think it all shows us that there's mainly neoatherosclerosis, the neointimal hyperplasia. That's probably the precipitating factor of failure of the stent. And of course, the extension of the disease more distally in the de novo or the native vessel as well, which probably caused the whole stent to eventually shut down.
There is some speckled plaque, and you can see there's some not so perfectly expanded areas in the stent, but that's probably the mechanism of failure. And this was obviously pre-shockwave. You can see right there, especially look how crushed that is. We're really going to have to expand this.
Wow.
So we're just going to pull back, and you can see again that part of the mechanism of failure is going to be the fact that the stent is not expanded well, in the mid especially. So we're going to have to do something.
I think we can purely go with the significant atherectomy device, which can do some aspiration component to it. And I think I would definitely do a vessel prep on this, but first I would probably do some aspiration atherectomy first, and then do the vessel prep. And I think there are areas where we might have to expand the stent, especially where there is a lot of calcium component.
Right.
So first choice for here, I would definitely start the vessel prep mainly with the atherectomy device first.
Some atherectomy, okay.
Yes, definitely. And then I would use a balloon to create our lumen and everything. But the areas the final modality is what we have to choose is the patient has already had a DCB failure. So we know. So we have to decide what to do. We have to do DCB one more time or anything. The final goal is what decides the third step.
Right.
Here. If you want to, if you're doing of DCB again and you think the primary failure here is because of lack of stent expansion, then we are going in the route in the way of shockwave and then trying to do DCB again.
So I'm just gonna. So we've got the rotational atherectomy here. What is it called? Our Rotarex. And some of the mechanism that I want you to look at is one. We've got the wire through. We've got the wire lock, and then we've got the flow bag, which is the most important thing with Rotarex. As we go down with Rotarex, it's phenomenal in cleaning out in-stent. And it has an indication for in-stent restenosis. In my humble opinion, this along with laser are kind of the go-to for ISR. Directional atherectomy is phenomenal, but it's off-label, and we don't want to talk about off-label things. The idea here is that this is a great device, and I think technique is important, and you got to make sure that you have flow. So as we get started, very, very slowly, allow it to go through. Michelle will just pinch the bag. Notice the blood flow in the bag. As the blood keeps flowing, that shows that we are able to keep it moving. And if the blood flow doesn't come, then that's an issue, right? So you can see you're a little bit of difficulty in working through. So I'm going to pull back and then trying to work through this area a little bit.
Back and forth.
Very, very
Pecking
difficult
motion.
to do.
Pecking motion helps.
A little bit more difficult, but we will be able to pop it through. And as it works through, we will know what's happening. And Karthik is going to keep kind of every now and then pinch the bag. You don't have to constantly pinch the bag, but every now and then just to make sure we have flow. So you can see here that it's a challenging lesion like we talked about, right? It's a very, very challenging lesion, and you can see here still, a little bit better flow, right? You're getting a little bit of flow. But again, we're just going to have to keep going from that point on and just go slowly. This deceleration is a real problem in the sense that you have to be very cognizant of it. So it's an expected thing that's going to happen. And the 8 French Rotarex actually works really well as well.
Yep.
So this is the 6 French we're using, right?
Mm-hmm.
Yeah.
Yeah, so rail and pull it. As you can see, it's you have to be confident, go through slowly.
It's not doing anything.
Going down really
I
slow.
would not.
No, that's
But it's okay.
I would not
Still-
do it.
It's still doing it. It's still atherectomizing, believe me.
probably not. Yeah.
It's still doing a good job. This part is going to be really hard. I know, because our catheter had trouble going. Okay, off. Let's walk it out. And let's do it again. Show me distal. You're coming out with it on?
Good.
There you go. So what Dr. Kapoor is worried about is that the device is stuck to the wire, which can happen. And that's why you want to make sure it's not
should
too
be out.
gummy. So here now we're taking out. We're going to clean it out again. And we're going to go again. This is the price you pay. It's a long segment lesion, guys. And so when it's a long segment lesion, a little bit of patience, a little bit of good stuff as we go through.
Here.
So it's starting to clear. See, if the audience can see the bag, you can see how the bag is now clearing and the blood is now flowing. So that's good. And you just got to pinch this like this and keep pinching it till you get fluid out. See? That's
this
all.
works.
Now you got it. See that? Now you're clean again, and we need to go back to the distal and continue and finish up.
Yeah.
So it's a little bit of patience, but it's worth the patience because you're going to see the result. I'm not going to come outside the stent with this. I'm just going to stop at the internal stent, and then we're going to talk a little bit about how we're going to treat that, and then we'll take it from there. Here, I'm going with a bigger shockwave, Karthik, just because I want to get as much expansion as I possibly can. With Supera, we're not going to be able to expand it any further, but the question is, have we debulked it enough in this situation? And it's always impossible to debulk the entire stent,
Correct.
So the idea would be is whatever our final therapy we decide to do, we'd like to debulk as much as we can.
I mean, also you can use an arthrotomy balloon.
We could use an arthrotomy balloon, or we can just use a regular balloon, So you can see that but the beauty here is from the IVUS, this particular device, the Rotarex has done a great job. And you saw the patients that myself, Dr. Kapoor, and Dr. Guja exhibited in terms of not pushing that all the way down. So remember, for those of you who say we're burning a bridge to bypass, this is already a disease spot. So we're not messing with anything where they can do a bypass if, God forbid, she develops CLI, which I doubt she will. She follows with us quite closely since we've been treating her for her claudication. So I think what we're going to do now is we're just going to go ahead and now make sure we IVUS this and make sure it's expanded. So you want to take it up to the proximal dot, and then you just want to pull the filter wire back and just do a half capture like that.
Yeah.
Maybe a little bit more than that, like that. And then you just want to come back as a system. No, it's opening up. So we'll just capture a little bit more. I think in this situation, we may have to lose the wire. Should we follow it? So you want to make sure the filter doesn't come off. If it does, then we have to deal with it. So this is like a half capture kind of situation. So for the audience at home, we were really talking a little bit about that osteal perineal. And you can see prior to, there was a double shadow there too. So it's not really a stenosis or an occlusion that we created. So we're okay with that.
So TK, now the plan is.
Plan is to
Sorry.
The plan is to IVUS, and then take it from there. Well, I mean, the idea is, if you feel confident that you took care of this and you expanded this, then that's fine. But to me, you've got 3 failures of drug-coated therapy, now you've done a good job of expanding it, right? So now the question is, do you want to leave it? I mean, I'm not going to cover that distal collateral.
Right.
I've already got a silver distally.
Can you do a spot Viabahn?
I mean, you
just
could
in
do
one
just
spot?
for the 5.0 and then just,
Yeah,
but
5 in the middle, and then DCB rest proximally and distally.
I mean, you could, but I mean, I don't know what you tend to gain by that. That's my point. I mean, you can reline the Supera with a 5.0, but I don't know that I'm open. I mean, I'm open to anything to really think about, but
I think that's what I would probably do. I would just that
Unless
area
you
where
put
the
two
calcified
different-
vessel is
Go
put a
here.
5.0 Viabahn because it's already 4.0, 5.0 Viabahn, crack it open as much as possible, get the maximal luminal gain, and DCB before and after the Viabahn.
well, the problem is, see, the Viabahn. The reason I'm doing the Viabahn is to exclude the plaque.
Right.
See, you're not going to be able to expand this Supera with the Viabahn down. The Viabahn is going to stay whatever size you're going to. The Supera, because Supera is not going to allow it to expand. So the question is, have you done a good enough job with the Supera? Go up now to reline it.
But we are
I think we
assuming
have.
that it's a 4.0
Yeah.
Supera.
The
Now
IVUS
the question is, what are we going to do? So I'm not going to touch the silver. I'm going to go to the Viabahn. I'm just going to go across just up to maybe right at the level of the silver area and then take it from there.
Yeah.
So the thing with the Viabahn is just pin and pull, and you can see here it's pinning and pulling. And I always tend to pull the wire all the way out. This way and then what I tend to do is not move my Viabahn because the markers are pretty poor. So you can see right there is the distal Viabahn. So it's right by 14. So I know where the last one landed. So now it's by 14. So now I'm going to get a. We're going to see what size we need. So this part is very important, as is the IVUS going to be very important for us to really understand what's going on. So now I'm going to take this in the IVUS. Now, a lot of the purists will be probably a little concerned that we put a silver distal, but I think, there's no choice here. We have to. So, we did what we have to do. We knew that DCB would not tack that up because of the level of dissection. So we're going here with a 70200 ultraverse balloon all the way down. It's an 0.8 balloon. It's a very good balloon. So we have now expanded this. We want to just get that ostium a little bit better. And sometimes, it may not get better. And the Viabahn is a great stent, but it's really on the operator to prep the vessel. And I didn't think I was going to go to the ostium, so I really didn't prep the ostium well. So hopefully this will expand and not leave a residual Vitrac. So the audience at home, I mean, we saw pretty much two spots of what is it called, infolding. So we're going to hit it with an 8015 Vitrac if we have it. Do we have it or no? If not, give us a 80 Ultraverse, please, or an 80014 balloon. So this is you can't really call this pave and crack or crack and pave. It's probably more hopefully this is going to work with a higher balloon. But I'm just going to tack it up because I saw that we're obviously got this little amount of infolding, and then take a look. So those at home, it's not filling that little posterior communicating artery because there's competitive flow through. See how it's filling through the arch.
Yeah.
So that's all
probably
competitive
also
flow. So I wouldn't worry too much about this. So just now your arch is
completing
filling
your
and
flow.
everything is perfect.
Yeah.
So I think you're done here.
Agree.
Just
So
want-
your 80 becomes a primary vessel.
Yeah.
to this
Yep.
one.
And I just take one more shot here just for my own health here and my mental well-being. And you can see here that I think it's beautiful. We're
Very
really
nice.
diseased vessels, but nothing different than what it was before. So, all right.
good.
Well, without further ado, we thank everyone who tuned in for this really exciting way of teaching, really 24/7. We all congratulate Dr. Mehta, obviously, for his foresight, Dr. Sharma for his foresight, and obviously Dr. Stone and the entire team for putting this together. We're really a pleasure for us to participate. We hope we've been helpful in contributing to your education. And please, we look forward to seeing you not only in MedStream 360, but also obviously with our CCC live cases that we do monthly. So.